Kia ora koutou. Welcome to our Heart Help Live series. A warm welcome to anyone joining us for the first time and welcome back to our previous viewers. I'm Jane Liggins, a heart nurse here at the Heart Foundation. Today we'll be discussing living well with atrial fibrillation, and we're really looking forward to answering some of your questions. So please feel free to drop questions in the comments throughout the session. You don't need to wait till the end when the Q&A part of the session begins. Now, it's my great pleasure to introduce you to Dr. Matthew Weber. Matthew is a cardiologist and a heart rhythm specialist, otherwise known as an electrophysiologist. He'll be sharing his expertise on atrial fibrillation, risk prevention, and clinical and lifestyle management before we move into the Q&A session. So without further ado, welcome, Matthew.
Thanks, Jane. It's a great pleasure to speak to the topic. I'm very passionate about it. Sometimes I get a bit carried away, but bear with me. Really intend for this to be interactive. Your questions are very welcome, and Jane will filter those through to me through the course of the session. Yeah, so atrial fibrillation, it's well, apart from being a mouthful, it can be a really confusing topic. It refers to the rhythm of the heart. Normal rhythm is normal sinus rhythm, and atrial fibrillation is an electrical issue that changes the rhythm from sinus rhythm to atrial fibrillation. Certainly early on in the course of atrial fibrillation, it is an electrical problem, but it can mature into something a little more complex. How do you detect it? How do you know that you've got it? Well, a lot of people are completely unaware. In fact, possibly the majority of patients with fibrillation are unaware of AF. They have no symptoms whatsoever, but it's still an important diagnosis. So how do we detect it? Well, the key clinical clue is an irregular pulse, feeling in what we refer to in medical terms as an irregular. The pulse just jumps all over the place, sometimes fast, sometimes slow, very irregular. But ultimately, the diagnosis of atrial fibrillation is an ECG-based diagnosis. You need an ECG of the rhythm to confirm that it is indeed atrial fibrillation, because many irregular rhythms, irregular pulses are not actually atrial fibrillation. But it is important to make that diagnosis of atrial fibrillation. We're really lucky to live in 2024 when there's lots of technology available to make recordings of ECGs, because the very nature of fibrillation, it comes and it goes. Sometimes you have the symptom or are aware of an irregular pulse for a short period of time, but it's gone again. It's back to normal by the time you go to the hospital or go to your doctor. The opportunity to capture an ECG is gone. So there are smartwatches now, which are very, very effective and reliable technologies for making an ECG diagnosis that's completely transformed cardiology practice. So if you have the luxury of accessing a smartwatch technology and making an ECG diagnosis, that can be critical to making the diagnosis. Why is it important? Well, it's important because there is a background risk of stroke associated with atrial fibrillation. And that doesn't mean that you have to be concerned that in the moment of fibrillation, if you don't fix it, you'll have your stroke. It's not like that at all. It's more that there's a heart that's prone to having fibrillation is also prone to triggering stroke. And that's probably the most important aspect actually of atrial fibrillation assessment, and why we're so keen to clinch a diagnosis even if there are no symptoms.
So Matt, can I just hop in here? Yeah. I do have a question here that says, and I just to clarify, this person asks, if I have AFib but don't have any symptoms, am I still at risk for stroke?
Yeah, that's a really good question, Jane, and that's a very clear yes. If you've even in the absence of symptoms, so you feel completely well, if you have a diagnosis of atrial fibrillation, whether it's there permanently or even if it's just coming and going for minutes at a time, hours at a time, but for the most part you're in normal rhythm, that stroke risk is still relevant. and it's determined by a whole lot of other characteristics about you. So one person with atrial fibrillation that comes and goes will have a certain level of risk of stroke. Another person with their high blood pressure and their high diabetes and increased age, that person would be at a substantially higher risk of stroke, even without symptoms of fibrillation, and would warrant a different treatment recommendation. And the treatment to reduce stroke risk in atrial fibrillation is a blood thinner called an anticoagulant. That's a sort of general term for several different types of medications which reduce stroke risk almost back to the same level as if you didn't have atrial fibrillation to start with. They're very important. They're not without risk. And so there does need to be a conversation about how much risk of stroke am I, how much risk is there with the blood thinner, and you and your doctor will make a decision about whether that's the right choice for you.
Actually, Matt, I'm going to pop in here again.
Yeah.
That's a really, really good point. I've certainly spoken with and looked after many patients who, certainly when they start their blood thinners, end up with quite a significant bruising or little bits of bruising, and there's worry that that's causing a bleed. And so we could maybe have a little discussion about that. And also the fact that there's several different blood thinners, aren't there? Certainly for New Zealand, there's warfarin and there's dabigatran, which also is Pradaxa, rivaroxaban. And do you have any suggestions about how people might manage that, particularly when they're first starting on a blood thinner?
Yeah, it's a really important consideration is the bleeding and bruising. So by definition, the blood is thinned by these agents. That's ostensibly how it reduces the stroke risk. But with that comes an increased risk of bruising, which is essentially low-grade bleeding under the skin, or it might be a more significant bleed. They're all fairly equivalent in terms of their bleeding risk, and the options that we have in New Zealand are Pradaxa or dabigatran and rivaroxaban, otherwise known as Xarelto. Warfarin achieves exactly the same thing, but it's a bit less common, or it's much less common, in fact, for use in this context. It's largely one dose fits all. There are two different doses of each of those two main blood thinners, and that decision is based on bleeding risk. And it doesn't need blood test monitoring, as opposed to the old warfarin, which does require blood test monitoring. So it's a matter of assessing stroke risk, determining that there was enough stroke risk to start a blood thinner, start the blood thinner, understanding what your risks are and seeing how you go, and then just making some very sensible and pragmatic decisions around hobbies. So I will say to people, look, if you love alpine skiing and downhill mountain biking, maybe you need to be a bit more cautious with your blood thinner. When you're pruning the roses, have a thick pair of leather gloves. Just some practical things around that. Just about all bleeding consequences of the blood thinners can be managed simply by manual pressure. You're not going to have a terrible outcome with many of these sort of superficial bruises and bleeds. There are other bleeds, of course, which are more important, but the incidence of those is really low, and certainly on balance, the benefit of being on that blood thinner exceeds that risk. But that's a really important conversation to have with your doctor. I'll move on to the next bit of the why is atrial fibrillation important. So if you don't have symptoms, we've made it a call about your stroke risk. The next thing is, what do I do about my symptoms of atrial fibrillation? What might they look like? Atrial fibrillation can make people feel breathless, dizzy, really dizzy sometimes if it makes the pulse rate go really fast, or indeed really slow. Chest discomfort, lethargy, lots of those kind of lifestyle limiting things that are so common and often caused by all manner of different things, but certainly could be characteristics of fibrillation. What do we do then? Well, then there are treatment options available. When it comes to treating symptoms of atrial fibrillation, there are two important treatment tenets. One is, do we just accept that the fibrillation will come and go, and we just look to control the speed of the pulse, because it's the really fast pulse that makes most people feel unwell when they're in atrial fibrillation. That's what we would call a rate control strategy. If we are looking to keep you in normal rhythm as our main strategy of managing the fibrillation, that would be what we call a rhythm control strategy, and there are a different set of medications to achieve that. There's definitely a move in recent years towards much more rhythm control than what we used to think was the right balance. And those medications are generally really well tolerated. They can be taken as a daily dose. They have a slow drip feed of rhythm control in the background, or it might be that just taking it when you need it, the so-called pill in the pocket or PRN medication, might be the right strategy for nipping in the bud that episode of fibrillation. I think another really important aspect of treating a given episode of fibrillation is to reassure you that it's not necessarily dangerous. In fact, it's not dangerous for most people in most situations. And I know certainly many of you in the audience will have been advised to ring an ambulance or attend your emergency department whenever you go into AF, or if the AF sustains for a period of time. Actually, it's probably not required. If you don't feel particularly unwell, many episodes of fibrillation will just sort themselves out in a short space of time. Others might persist for much longer, but if you feel okay, it's okay to wait until the next day to speak to your GP or to your local family doctor. You don't necessarily need to be jumping into the ambulance. So that notion that it's not dangerous is a really important one. That said, some people feel very unwell in the moment of going into atrial fibrillation, and of course, if those symptoms don't settle quickly and you feel very unwell, then of course an ambulance and attending acute medical services is the right approach.
Matt, I've got a question here from Sandy, and she asks, where's that question gone? I know it sort of links in with what you're saying, but also in the signs and symptoms of AF. She's asking, is chest pain part and parcel of AFib?
Not necessarily. So if I could sort of paraphrase that to make sure I've understood the question, not all chest pain is caused by atrial fibrillation. That's an important point to make. Also, not all episodes of atrial fibrillation will cause chest pain. In fact, the experience of atrial fibrillation will vary greatly within a person and between people. Some people just experience breathlessness. Some people just experience palpitations. Palpitation feels like a fancy word, but it just means an awareness, an awareness that you wouldn't normally have of a fast or an irregular pulse. You'll go on a journey with atrial fibrillation. You'll begin to learn what your triggers are, what your experience of atrial fibrillation is. And as you get a bit more experienced in that journey, you'll get a feel for, yes, this is just my atrial fibrillation, and I can accept this and carry on. Or it might be a brand new experience. So normally your fibrillation might just be an awareness of an irregular pulse, and then on Thursday last week it came with chest pain. Well, that's a new characteristic for you that would warrant additional assessment because it might mean something different. Apart from the medications, in terms of managing atrial fibrillation, there are also really important lifestyle considerations, both in terms of your overall wellness and avoiding getting atrial fibrillation or avoiding fibrillation getting worse. Those things would, the three key things I think around reducing your overall or increasing your overall wellness, reducing your overall risk, would be around maintaining a generally healthy lifestyle. No one diet in particular is important, simply a healthy, balanced diet. And that's very well described on the New Zealand Heart Foundation website. I certainly don't advocate eliminating that particular food type or having an exclusively meat-based or fat-based diet. I don't think that's a balanced approach, and it's not necessarily required. Keeping alcohol to the low is important. Is really important. I love my IPA beer, but sadly, there's no safe level of alcohol, and the key message really is the less that you can get away with, the better. I think we'd say 2 to 3 units in a week is a reasonable compromise, but even that might be a trigger for you, for any given individual, and perhaps reducing it to as low as you can go is a good position to take.
Yeah, I agree, Matt. I'm sorry, popping in here too. Yes, the Heart Foundation's put out a new position statement on alcohol, and unfortunately, the old message of red wine is good for your heart has been debunked, so that's no longer something that stands up to current research, which is really disappointing, but our message is along the same line. So really no alcohol, there's no safe amount of alcohol to be taking for your heart. We have to be realistic too, so your message of 2 to 3 units a week is probably fair, considering that for many people it's an enjoyable part of their lifestyle in moderation, but also certainly from my experience with patients too, for quite some number of patients who have episodics, atrial fibrillation that comes and goes, alcohol is a trigger for them. So if you will find out yourselves whether you notice if you're drinking a glass or two of alcohol, whether that actually triggers your atrial fibrillation or not. Really good messaging around. And if you never drink out, you haven't drank alcohol, great reason not to take it up. And if you are drinking alcohol, maybe just watch how much you're drinking.
Yeah, I think that's a really sensible summary. The exercise is important. Exercise is important in terms of keeping our overall bodies well. I think whilst we're focused on atrial fibrillation tonight, it's important to acknowledge that we're treating this in the context of your overall health, and just focusing on rhythm or just focusing on diabetes is not constructive. We have to think about the whole picture. Having a fit and active body is a really important part of quality of life and maintaining a healthy body, and that certainly applies to atrial fibrillation. But I also acknowledge that for some people, atrial fibrillation can be a trigger. And beg your pardon, exercise. In the moment of exercise, fibrillation may occur, and it may appear to occur more frequently when you're exercising than when you're at rest. But that doesn't mean that exercise is unsafe for you. Overall, your overall health will certainly be better for being physically active, again in accordance to the sorts of levels described on the Heart Foundation website. If you were to get atrial fibrillation during your exercise, it's just simply a matter of slowing down that exercise session in that moment, take a rest, and make your way quietly back home again. But don't be discouraged to try it again the next day. If there is this pattern of recurrent fibrillation with exercise, then the onus is on me to give you an alternative tool for managing it so that you can carry on that exercise. So I think that's really that nutrition and exercise message in alcohol is just so important. Yes, body weight is important. We are reminded of that, but I focus much more on healthy nutrition, healthy exercise. If you're doing both of those things as well as you can do, and you've got a reasonable understanding about what healthy nutrition looks like, then you're doing your best. And I'm not too tough on people about on the body weight aspect of things, because it's just not constructive.
Well, Matt, that's fantastic. Sorry, I totally agree with you. And I just wanted to pause for a moment and just thank all the audience out there, all our viewers, for joining and leaving so many questions in our comment section. We're really enjoying this and appreciate you giving us some of your concerns or questions so that we can help answer those for you. And we will do our best to get through as many as we possibly can. And I'll interject every now and then, sorry to interrupt, Matt, just to see if there's a pertinent question to what you're talking about, just so that we can answer it within that section. And I've got one here from Prue, actually. She asks if AFib makes you short of breath when you're going from medium to high exertion when you're exercising. She was very fit, but now struggles walking up hills. Is this common?
Yeah, absolutely. That's a very classic description of atrial fibrillation. In fact, some people are only aware of it when they go to do things. When they're at rest, the atrial fibrillation doesn't really impact too much, not even aware of it. But as soon as they try to exert, at a low level impacted a little bit, at a higher level of exertion impacted even more. Doesn't mean it's more dangerous. It just means you're simply more limited, because you're asking more of your body, and the state of atrial fibrillation is just less efficient. You just got less pep when you're in atrial fibrillation. So that's a very classic description, yeah.
So, Matt, again, just thinking about, the message really is to be doing some exercise. It's really important for general health. It's really important for overall heart strength. There may be some difficulties with what you had been doing perhaps before your diagnosis, or starting a new medication. So one of those rate control medications like a beta blocker. But the overall message is to continue to do something. Things should improve. Is it really any other messages around that?
I think that's an important point. I think all health professionals will acknowledge that the medications will come potentially with some side effects. I think one obviously the ultimate goal for all of us is to make you feel better, that there'll be a net benefit of the medication over the side effects. And if that's not the case for you, then of course there's flexibility in changing that. There are different medications and different strategies. One thing I will say is that some people experience side effects early on in their medication journey, but get more accustomed to them, or are not affected as much by their medications 2 or 3 weeks into that experience. So I would encourage you that if you are recommended to have some medication, that you do give it a good trial, both to determine whether it helps, and B, to determine whether any potential side effects get better, because they often do. But it is an important conversation about that sort of pros and cons thing with treatment, and that's where different treatment strategies, that conversation comes up as well. So maybe there's actually a couple of procedures for atrial fibrillation. Early on in an atrial fibrillation experience, it's an electrical problem coming from the pulmonary veins, some electrical extra beats that are coming from the pulmonary veins in the back of the heart. So we can offer an operation called pulmonary vein isolation, where we cauterize around the vein that is causing these triggering beats, and that's a very effective, not necessarily curative. In fact, it's not curative most of the time, but it certainly is an effective strategy for managing atrial fibrillation. Not all atrial fibrillation, not everybody is suitable for that, but it's definitely a conversation to be had, particularly if atrial fibrillation is new for you. It's a new diagnosis. The fibrillation is coming and going of its own accord. That's probably a good time actually to just talk about the different types of atrial fibrillation. Atrial fibrillation is atrial. Oh, sorry, Jane.
No, keep going. Sorry.
Yeah, I was going to say, yeah. I mean, atrial fibrillation is atrial fibrillation, but how it behaves, if episodes are lasting less than 7 days and then they stop, whether through treatment or by themselves, we call that paroxysmal atrial fibrillation, bursts of fibrillation. And that tells me, as your doctor, that this is definitely an electrical problem. It will respond really well to treatment. It will respond very well to your lifestyle choices, and it will respond well to all of our ablation, rhythm control treatments. As atrial fibrillation matures into longer episodes, more than 7 days, we call that persistent. Of course, persistent's not persistent. It's not going all the time. It just means that a given episode lasts more than 7 days. It might still be, hopefully, an intermittent persistent process. That's a atrial fibrillation that's become a little bit more ingrained for you. and is a little bit more difficult to treat. So we really can't emphasize enough the importance of making the diagnosis and treating atrial fibrillation early. Have that conversation early with your doctor. Get on to these interventions early so that we can prevent this condition progressing into a more persistent or even a long-standing persistent episodes that are there for 12 months or more. That becomes a very difficult situation to get back to normal rhythm. And that is our ideal, to get you back to normal rhythm. Unfortunately, for some people with atrial fibrillation, it's just not achievable to get back to sinus rhythm. But that's okay. That is okay. It's okay for most people in that situation. And you can still live very normally. In fact, I've got marathon runners who are in fibrillation all of the time. No symptoms, running marathons much quicker than I ever could or would. So it's certainly not a fait accompli, but I think it is important to get onto it early if you have that luxury to do so. Yeah.
Matt, in that vein, and I'm not sure whether you were going to go on to talk a little bit more about other treatments, non-medical treatments for atrial fibrillation, but I've got 2 or 3 technical questions here I thought you might be able to quickly answer, please, from our viewers. We have Martin, who's asking, when is a left atrial appendage closure recommended?
Right, that's a complex question. So just to back up that one a little bit for listeners, your left atrial appendage just means an outpouching, an extra bit. Your left atrial appendage is an extra bit attached to your left atrium, and it is thought to be a really important part of the stroke genesis with atrial fibrillation, so that if we close off that appendage, we might reduce that risk of stroke. And certainly there are devices out there that do that and do reduce that risk of stroke to about the same degree as a blood thinner. So not better, not worse, just different. But it is an operation. So there's extra complexity. 100% blood thinners are the mainstay of stroke prevention, but left atrial appendage occlusion does have a role in a small number of people. It's often undertaken when it's in combination with a surgery for another reason, maybe on another valve in your heart. You might be recommended to have appendage closure in that context.
Yeah, it's quite a big deal. It's quite a big deal, actually, isn't it, Matt? Because it is a major surgery and may or may not be necessary, but that would be individually.
It's pretty complex, but it may absolutely. It's a valid thing and well respected.
Now, Craig asks, how long does ablation typically last? And I think he's referring to the standard AF ablation, radio frequency or cryoablation.
Yeah. Thanks. How long does it last? So we would expect that you would have out to 12 months after an ablation procedure, about 70 to 80% of people have no awareness of atrial fibrillation. 70 to 80%. If you compare that to medications, you might be looking at 50%. So it's substantially better than drugs, but neither of them are curative. The longer out you get from your ablation procedure, the higher the likelihood that some fibrillation will come back. But you're still looking at really good long-term outcomes, even out to 15 years. 15 years after an ablation, maybe only 50% of people have had an awareness of atrial fibrillation after their ablation. There's a caveat, of course. It depends what type of fibrillation you have and what the rest of you looks like in terms of your overall health. But if it's been recommended for you, and certainly in the New Zealand context, we're very careful about who we take on for ablation because it's involved. You can certainly be enjoying outcomes along those lines.
Matt, we've got heaps more questions coming up,
Yeah,
but
go
I
for your
think
life.
you've got some more important points to finish, have you? Or do you? Is
Oh no, I
anything?
think I'm pretty. I think I've done all my prepared material, Jane. Let's hit those questions.
I'll try and group them in themes just so you're not feeling that you're all over the place.
You're good.
But just a few questions again about controlling atrial fibrillation. We've got Carol thanks Carol, who wants to know, good question, if AFib can lead to an enlarged heart.
Yes, atrial fibrillation can lead to an enlarged heart. It certainly can. It's not the experience for most people. And I kind of come back to that point that if you're feeling well, you just carry on, and you don't worry too much about those sort of finer details. But certainly, if you have untreated symptoms of atrial fibrillation, you can come to harm with it. There's no doubt about that. We know that more people have to go to hospital if you don't treat those symptoms. More people have what we call heart failure. It's a slightly dramatic term. It's not a very helpful term. It's not that your heart's kaput and it's not going to turn up for you tomorrow. It just means that it's not meeting your needs. Well, certainly untreated symptoms of atrial fibrillation can result in heart failure and an enlarged heart in some people. Be guided by your symptoms. Be guided after that initial diagnosis of atrial fibrillation has been made, and your stroke assessment has been made and taken care of. Then after that, be guided by your symptoms. Don't be guided by your watch. Don't be guided by all of this data. Be guided by how you feel. If you're feeling well, your treatment's spot on for you. If you're not feeling well, something needs changing.
Perfect. Thanks for that, Matt. Molly asked, does having atrial fibrillation and a hole in the heart need special management? I know that's a little tricky too, not knowing Molly's history. Sorry, Molly, but I just thought I'd put that out there to Matt to answer briefly.
Yeah, absolutely. It can do. Not every time. It depends on why that hole's there and how big it is and what consequences it's having. It might be completely unrelated to the atrial fibrillation, or it might be very related to the atrial fibrillation. That's a conversation to have with your heart specialist. Holes in the heart can be implicated in stroke risk. It's a very rare scenario, but it's an important scenario, and tackle that one on a person by person basis.
Thanks, Matt. And a couple of medication sort of themed question. Isabel, thank you, Isabel. Great question. How do I know when my atrial fibrillation is controlled so I can stop my meds?
If you're feeling well, your atrial fibrillation is well enough controlled. That would be, I think that's a reasonable comment. That doesn't necessarily equate to stopping your meds, because you may well feel well because of your meds. And I take a very pragmatic approach with medications. My position is, if you're not having side effects and your atrial fibrillation is well controlled, then you've actually got very little to lose by carrying on those medications. The benefit almost certainly will exceed the downside. So please continue. Particularly if that treatment you're talking about is your stroke reduction treatment, your blood thinner. If your doctor has determined that you are at sufficient stroke risk based on your age and your high blood pressure status and diabetes, so on and so forth, that position's never going to get better. So please continue that blood thinner indefinitely. There are circumstances where blood thinners can be prescribed for discrete periods of time, but most of the time, once a decision has been made for you to have a blood thinner, you ought to continue on it indefinitely. So it's important to make that distinction between what am I trying to achieve with those? What is the medication there for, and is there a role for coming off them, or indeed changing them? There's often a role for reducing medication. I'm frequently doing that in my practice when I'm trying to strike that balance between benefit and harm of a given medication. But that's mostly driven by how people feel. It's mostly driven by how if people tell me they're feeling well, there's nothing really to improve on feeling well.
Thanks, Matt. That's a really clear message coming through. So basically, for many people, or most people, the reason why they're feeling well and their symptoms are under control is because they're taking the medication. But as soon as they stop because they're feeling better, they run that risk of stroke, damage to their heart long term, and their symptoms returning. So best to stay on them or to talk to their GP or doctor about reviewing the medication, possibly either changing one or reducing the dose.
Undoubtedly.
Yeah, cool. A couple more questions. Heather asks if you're aware of new medications being developed for AF symptom management. Specifically, is there anything better than flecainide? I think, Heather, I remember your question, you're having some side effects and problems with flecainide.
Development of new medications is slow. There's not a lot of change in that space. That said, there are alternatives. So flecainide is one of those rhythm control medications as opposed to the rate control pills. And there's 3 or 4 main classes of rhythm control medication. So if you're having troubles with flecainide, it's probably best to speak with your doctor about would one of the alternatives be appropriate for me. That's also the right time to ask whether an ablation is suitable for you, because an ablation is trying to do the same sort of thing that flecainide is trying to do for you. Maybe that's certainly a valid question to ask.
Thank you. And thanks, Isabel. You've got a question here. Will AFib progress to chronic if I'm taking the correct meds?
Really good question. Yeah. Chronic. The word chronic usually means all the time, I think, if that's what your question is. That we don't use that word so much now. We've changed to that paroxysmal, persistent, permanent nomenclature. If the majority of patients will not progress from one form of fibrillation to the next, the majority will not. That said, if you want to get the best response to your treatment, it's best to start early and to continue with those medications for the foreseeable future. If those medications aren't working for you or suiting you, then ask for a change. But the best results are achieved when you start that treatment early on in your journey. Sometimes there's very discrete and clear-cut causes for your fibrillation, and a really good example would be you've got a overactive thyroid that's very, very active, and that's driving the fibrillation, and you treat the thyroid and the fibrillation then goes away. That might never come back for you ever again, and maybe no treatment is required. But that's the exception to the rule. Usually there's no clear identifiable trigger or cause for fibrillation. It just is. It just comes and it goes. Why? Because it's primarily an electrical problem coming from those veins in the back of your heart.
Thanks,
You've not done anything wrong. Your parents haven't done anything wrong. It just is.
Right. Oh, thanks. It's really reassuring, that. Good question here from Corrine. She says that she started with SVT, so that's supraventricular tachycardia, and it moved to AFib. Is that common?
SVT is common. Atrial fibrillation is common, and they certainly can be linked. So it's something that we would always go looking for. If I meet particularly a young person with atrial fibrillation, it's a bit unusual to see atrial fibrillation in someone less than 30 years of age. If I was to see that, I would certainly go looking for SVT in that person, because it might be that if I fix their SVT, and ablation is very effective for SVT treatment, in fact, it can be curative, then I might fix their fibrillation, and that's the end of that. SVT is seldom the cause of atrial fibrillation in older people, so we tend not to go looking. But certainly if there are clues to SVT in a person, then we would certainly target that, because it's a much easier problem to treat, and as I said, can be treated curatively, particularly with ablation.
Fantastic. Thanks, Matt. They're coming thick and fast now. Thanks, guys. You're doing great up there. Wonderful
Don't get up
viewers.
ahead of steam, Jane.
How are you going, Matt? You're holding up?
Yeah, no, I'm on it. Maybe I'll have a sip of water. Not alcohol.
Well, you have water, and I'll just I'm going to have a look at these questions and again try and group them together. There's some really great engagement and great questions here. Thank you so much, viewers. So I'm going to try and get through as many as I possibly can. Shirley asked, what help can a pacemaker be for AF? Just keeping into that sort of treatment theme.
Oh, I'm pleased you asked. Thank you. I meant to speak to pacemakers. Pacemakers are tremendous technology. They don't help you stay in normal rhythm. They're not a rhythm control option, but they can be really helpful, particularly if the medications you're taking sorry, maybe I should back up a little bit. The main role for a pacemaker is to stop the pulse rate go slow. All right. A pacemaker sets a lower rate and ensures that your pulse never goes too slow. That's not usually the problem with atrial fibrillation. Usually it's too high. So what can be required, particularly in older people, is medication to stop the pulse going too fast and a pacemaker to stop the pulse going too slow. And then we hit the sweet spot. That's where pacemakers have the most value treating atrial fibrillation.
Thank you.
They're not an upfront treatment for most people.
Thanks, Matt. A few questions here regarding the environment, I suppose, and other causes for atrial fibrillation, or triggers, should I say. Willie asks, in summer, is it normal to sweat a lot, especially if walking?
Definitely it is. I sweat profusely when I exercise, particularly in the summer. Not necessarily a symptom of fibrillation. There are certainly some curious symptoms related to atrial fibrillation. Possibly more common than heavy sweating would be wanting to go for a wee much more frequently. That's sounds a bit unusual, but it's definitely a thing.
Matt, that's brilliant, because that's an extra question. Angie asked, is there a link between excessive urination and atrial fibrillation?
Yeah. So that's Thanks, definitely a thing. That's definitely a thing. And we just cross each of those bridges as we come to it, because it can be so variable between patients. Some people need to drink more. Some people need to drink less. Some people find that when they eat a certain type of food, they get fibrillation. Other people have the opposite experience. So we have to kind of tailor that according to your experience, and you'll get a feel for what works for you, what triggers seem to make things better or worse for you. I was just going to speak to cardioversion, Jane, if I may.
Sure.
That's another question that comes up. A cardioversion is when people get an electric shock to get the heart from atrial fibrillation back into sinus rhythm. It's not required for most people with their atrial fibrillation experience, but it might be something that's recommended for you if you're in fibrillation for a fairly long period of time, say weeks or months, and it's not clear whether your breathlessness is due to the fibrillation. A doctor might recommend that you have an electrical cardioversion to get you back into normal rhythm, and all of a sudden you feel so much better. Then we know that the fibrillation was the cause of your problem, and we carry on that journey of ongoing rhythm control. The cardioversion won't keep you in normal rhythm. It gets you back into normal rhythm, and then you need something else to keep you in normal rhythm, so-called rhythm control, be it medications or ablation.
Brilliant. Thanks, Matt. That's a really important message. Kylie wants to know why she feels her atrial fibrillation more when she has a cold.
It's a great question. I think it's probably because when you have a cold, your system is a bit more stimulated, and so you're a bit hyper aware of. So our bodies have a nervous system which keeps us alive, essentially, and runs all the things that we don't have to think about, our pulse rates and our awakenedness and things. When we have a cold or a flu, that system is heightened and more fired up, and so it makes us more aware of irregular and fast pulses. It might also be that the cold was the trigger for the fibrillation. Before the cold, you weren't in fibrillation. You get the cold. It's a body insult, as it were, and that's enough to trigger the fibrillation. When the cold goes away, the atrial fibrillation goes away. That's quite a common experience as well.
Thanks, Matt. That's great. A great question here too from Juliet. Thanks, Juliet. I've heard there's a correlation between sleep apnea and AFib.
Oh, excellent question. Sleep apnea, yes. Apnea is a fancy word for stopping breathing, and sleep apnea is stopping breathing when you're sleeping. Clue, snoring, and then waking up in the morning feeling like you've not had a restful night's sleep because you've been stopping breathing and waking, stopping breathing and waking. That's your body's reflex. Waking up is your body's reflex to start breathing again, and you get into this cycle. Disrupted sleep, tired the next morning. There's a very strong link between sleep apnea and atrial fibrillation. So if you have been diagnosed with sleep apnea based on those characteristics I just described, of the sense in the mornings that you're just waking up not refreshed and you're a snorer, then treating sleep apnea is a really important thing to do. What are the treatments? People who are not conscientious with their nutrition and not conscientious with their exercise tend to be much bigger people, but being a bigger person certainly increases your risk of sleep apnea. And then if fixing those things isn't enough to stop the sleep apnea, then moving on to a mask that assists your breathing and opens your airways up. Very effective treatment for sleep apnea. Really important thing to do if that's something for you.
Thanks, Matthew. That's great. Now, we've had several viewers asking, is AFib hereditary?
Oh, that's another good one. The short answer is that it's not for most people. It's such a common problem. Like, we're talking 5 to 10% of the community experience fibrillation at some point in their life, that makes it almost impossible to determine whether your family history is relevant or not, because there's such a high likelihood that you're going to get it anyway. You can't do much about your family history. I tend to focus on the things that I can change, and you can't change your parents. So it's a thing to maybe have in the back of your mind, that if every family member had it, then maybe you have more of a disposition to it, but it doesn't take away the responsibility for all of us to do all of the things that we can to avoid it, or to reduce the likelihood of it. And I come back to those just very basic but really important lifestyle things.
Fantastic. Thanks, Matt. Richard asks, can low potassium affect AFib?
Yep. So our body runs on ions, IONSs, positive ions, negative ions, if those of you that remember your school chemistry. And one of those important ions is potassium. Certainly if your potassium is up or down for whatever reason, due to your medication or due to another explanation for you, absolutely it can increase the likelihood of your fibrillation and change the way that your medication works. Yes.
Thanks, Matt. Now, there's been a few viewers too asking about, as we sort of touched on exercise, whether there was a better or best type of exercise for people with AF and how much exercise to do and at what intensity. And that's quite a personal.
Yeah, that's a really good question. I think your Heart Foundation website covers this very well, so it might be a good opportunity to have a wee look at that, because a moderate amount, essentially what you can achieve in the midst of your busy working and life day. You might be able to help me, Jane, exactly what the Heart Foundation website says about it. But I would advocate, 30 to 40 minutes of purposeful exercise in a day is ideal. And when I say purposeful, I mean working hard enough that you feel breathless, that it's not just an amble, that you're purposefully and working hard. Whether that's lifting weights, whether that's what we call cardiovascular or aerobic exercise, walking, swimming, cycling, those exercise with those exercises, it's less about the muscles and more about the heart and lungs. Either of those is good. And if you have the luxury of getting 35 to 40 minutes, that would be ideal. And then, of course, substituting anything, squeezing it in wherever you can in the day. So substituting those car journeys and bus journeys and train journeys with a longer walk or maybe a bike ride if you're not going to get knocked off. Any of those little bits of activity also add up during the course of the day to a more active lifestyle. It all helps.
Yeah, I totally agree there, Matt. Spot on. It completely aligns with what the Heart Foundation really try to let people know about or have a strong message around, which is 30 minutes or more, ideally most days of the week. So maybe 5 days a week would be ideal or more. And also aerobic exercise is really important. So it's not a specific type of aerobic exercise that is more suitable for people who may be living with AF. It does depend a lot on you and your age and your interests and your activities and any other possible medical conditions that might restrict what you can do. But there's always something out there for everyone. And I think too, certainly as we age, it's really important to do a combination. So the aerobic exercise, very important for your heart, but also some sort of strength training. And that doesn't need to be lifting weights at the gym. It can actually be some body, using your body weight to be doing some planking or some wall exercises or some small weights, that you can literally buy for a few dollars and find some good sort of strength training type exercises online that you think you can manage is really important too as we age. So that combination of strength training and aerobic exercise is ideal.
Absolutely. And you can't really do too much either. Don't be concerned that you are likely to be overdoing it because the reality is for all of us in our busy lives, unless you're a dedicated full-time professional athlete, it's very hard to do so much exercise that you actually are doing yourself harm. If you're, I'll leave it at that. That needs to be said, really.
No, that's a really good message too, Matt, because I can imagine if you're newly diagnosed with AF, you're worried that, particularly if it's a trigger, and you tend to under-exercise rather than overdo exercise. So it is safe to exercise. You're taking your right medication, just as you would normally do, just build slowly. Incremental improvements or length of time.
That you like doing. Choosing something that you like doing, because what we want you to do is not just to do it after tonight's lecture. We want you to do it next week and next month and next year. That's where the real benefit is. Maybe liking is not the right word. Maybe disliking the least for some people with exercise, but just choose something that you can keep doing. Find a friend. That's how that's what keeps my motivation. I have to meet some person at some time. That makes it easier for me. I think that's helpful.
Yeah, that's fantastic, Matt. A couple more, and then I've just got some main message I thought you and I could just wind up with is what we really want our viewers or all you wonderful people out there to go away thinking about. Raymond's got a question. I think this is really important that we acknowledge that for some people, you're managing and living well with atrial fibrillation. The diagnosis was some years ago, and you might have had a few ups and downs and changes, but now you're feeling reasonably comfortable with managing yourself. But certainly for someone who's been newly diagnosed with AF, it can be quite a shock. It can cause some anxiety and some stress, sometimes depression. And Raymond here asked about she's newly diagnosed with AF, and it's the first time she's ever had to take medication. And just getting over that barrier of having to start a regular medication long term can be quite confronting. Do you have anything to add to that? Or?
Yeah, I think that's a really valid comment. It can be very frightening when you first have a diagnosis of something, particularly if you've lived with no medical conditions at all for a long time, and this is your first. A strong dose of reassurance is probably the first thing to say. That it doesn't mean you're an outlier. It doesn't mean that you're diseased or there's something really important wrong. It's just a thing, and it's a thing that can be managed very effectively. Most people can live very normally, and don't don't feel like there's any stigma around being on some treatment. If it's just a pragmatic decision about benefit versus harm, and if you are recommended to have a medication, it's because we think you're going to do better. We think you're going to feel better with the medication as opposed to without the medication. And think of it in those positive terms rather than, oh my goodness, I'm not the person I used to be. I'm now taking regular medication. And I'm fully on board with that notion of, I wish I didn't have to take medication. I'd rather not be taking medication. But what we're all trying to do is make you feel better, and so that there's a net benefit. If that means you're on medication, then you're better off on it than off it.
Yes, certainly, to try and help prevent some, longer term problems like stroke and like heart failure. So absolutely, just think of it as a good investment for your long term health.
Yeah, absolutely. And some people will say to me, "Look, Matt, I've been really good. I've been really good all of my life, and I'm 66 now, and it's just happened. What have I done wrong? You've not done anything wrong. It just means that had you not been as good as you had been or have been, you would have had this problem 10 or 15 years earlier and been dealing with this problem a lot sooner, with more complications. So, congratulations to you. If you are 75 and having your first problem, that means you've been doing something right for a long, long time.
Fantastic. Quick question, and then we'll just sort of wrap up here. And I think it's a really good one. Paul asks, if you've been diagnosed with AF, are you more susceptible to angina?
Good question. So angina is the term we use to describe pain coming from the heart. So angina is a sense of heaviness or pressing across one's chest. Typically it happens with exertion because you're asking more of your heart and of your body. And so when there's a blood supply issue, it's not meeting your demand, your need, and you get this chest pain. The state of atrial fibrillation is a bit like a version of exercise. It's a bit like a heart working a bit harder. And so it can be, you can get angina sooner than if you weren't in atrial fibrillation, because often people in fibrillation, their pulse is 100 beats per minute as opposed to 60 or 70 beats per minute when they're in normal rhythm. And so there's greater demand on the heart, a higher likelihood of getting angina. Yes. Most people don't develop angina and coronary disease until their middle and older age. But certainly if you're getting heavy chest discomfort in the context of your palpitations or your known atrial fibrillation, that's an important question to ask of your GP.
Thanks, Matt. That's great. Another quick one I'm going to quickly answer before you give you a break. Nikki asked, does stress bring on AF? And yes, Nikki, stress can be a trigger for AF, and it is quite personal and depends on you. And there's quite a lot of information on our AF page that I think one of my colleagues is going to post, if she hasn't already, on the chat. So a link to our AF webpage at the Heart Foundation, also a link to our journeys, stories of real New Zealanders telling their story in their own words of their experience with atrial fibrillation. So have a wee look at those. And Barbara, you've got a question here about, is ablation the best procedure for AFib? And I think you've answered that earlier, Matt, as far as is atrial fibrillation suitable for everyone.
Yeah, it's pulmonary vein isolation ablation is the ablation for atrial fibrillation. And yes, when you compare it to rhythm control medications, it comes out on top. But it isn't suitable for everybody. And it depends on your overall health, and it depends on how long you've had atrial fibrillation for, and whether it's just coming and going or whether you're in it all the time. Those things all come into that question. But yes, it's an excellent treatment, and it's a growing treatment, and there are new technologies with that treatment coming out. It's a very exciting field, but it's not for everybody. It's an important conversation to have.
Oh, that's great. Thanks, Matthew. I've just written a few little main messages here, and please add to them if there's anything else that you would like all our viewers to go away and have a think about. My main messages are that everyone experiences atrial fibrillation differently and has different causes and triggers and therefore different treatment options. So for you, just remember if someone else has AF and they've had ablation or experienced different symptoms, you haven't done it wrong or you're not missing out. It's just that it is very different for each individual. We've discussed that quite a lot throughout this session. So the best thing to do is to understand as much as you can about your AF and your AF experience, work out what triggers, how you can manage it best and to avoid those triggers. If you have concerns, talk to your GP or your nurse or pharmacist about that. And just to be reassured that although it generally is a long-term condition, many people or most people manage their AF well, and there's no reason why you can't live a long and active and good quality normal life. Anything to add there, Matt?
No, spot on, Jane.
Fantastic. Well, that brings us to the end of tonight's session. Thanks so much, everyone, all of you that have joined us this evening and all for your fantastic questions and engagement. A huge thanks to Dr. Matthew Weber for being here tonight. We've been absolutely fantastic, really nice and clear with answering your questions, and your expertise has been really, really appreciated. To everyone watching, thank you for joining us and again asking some fantastic questions. We hope that you've gone away and found this session really useful. Goodbye and look forward to seeing you next time. Thanks, Matt.
Bye-bye.
Bye-bye.